All right, good afternoon, everybody. My name is Bronwyn Edwards. I'm from Roses in the Ocean, and with me is Mitch from Beacon Strategies.
Hi everyone, how you doing?
Thank you so much for joining us. So first of all, I'd like to acknowledge the traditional owners of the land on which we're meeting today and pay our respects to the elders past and present and emerging voices. In particular, I'd like to acknowledge the traditional owners of the people of the Mid-North Coast region. So that is the Worimi, the Biripi, Dunghuti and the Gambanga. Please excuse me if I've not pronounced those exactly as they should be. I'd also like to acknowledge the people with a lived experience of suicide who may be joining us today or going to watch this webinar over the next few days. Thank you so much. Thank you also to all of those people with lived experience out within your region. We acknowledge the courage it takes to speak up and bring your experience to the table. We acknowledge also that a lot of health professionals come to work every day with their lived experience, and for many others that suicide absolutely impacts everyone in our community in so many ways. So today we are going to just bring you up to speed with where we're at in our part of this co-design process, acknowledging of course that there's, we understand there has been some significant work done as well within community to date. So I will go ahead now and share my screen. We've got a whole set of slides for you that we'll take you through, and at the end we'll have some time for some questions and answers if anyone would like that. So just bear with me while I share screen now. And then we will be underway. So, first of all, let's just have a look at the process so far. So we have been invited to come and work alongside the Mid-North Coast LHD in the co-design of your alternative to ED safe space. Hopefully you've had the opportunity, the time to watch the orientation webinar and also read through the information pack that has been provided on the Roses in the Ocean landing page. The Ministry of Health have statement of requirements with regards to the alternative to ED safe space and also the suicide prevention peer workforce that will staff these safe spaces. They will be up on our website very soon. We're just waiting for the Ministry of Health to release the final versions. There have been a number of iterations over the last few months, but that we should have them sometime this week. So what we have done is we have had small group focus conversations with health professionals, and there's also been a face-to-face group lived experience workshop that's taken place last week. So the purpose of this feedback loop number one, this is the one for health professionals. There was one just a couple of hours ago with Carrie and Tina who were feeding back on the process so far with the lived experience inputs. So the purpose of this is to provide the context of the whole co-design process. Where are we up to? Make sure we've captured everything that you've shared with us so far, and so that we can add that to the previous co-design work that's already been undertaken by the LEOS group and by the LHD. The purpose is also very much though to gather broader views and experiences from within the health professional networks and the wider community and people with lived experience, explore what's missing, and all of that will help us prepare for the next round of the co-design process. So, we want to acknowledge that there has, as I've said, there has been work undertaken by the local health professionals in the Mid-North Coast LHD region, and that our aim is to collate and utilise those insights that have been generated to date, and ensure that this process is respectful of the thinking that's already taken place. Now we have been provided with some of the work that the lived experience of suicide group, the LEOS, had done prior to Roses in the Ocean being involved, and that was incorporated into their work last week. We're still just waiting to get access, which will happen very soon, I think, to the work that the health professionals made us aware of when we did the small group conversations with them. So we look forward to doing that. So the perspectives presented in this slide deck have been generated from our conversations with those health professionals to date. The project team will be accessing that, and so you'll see the work that's come before this, you'll see it start to be folded into the process going forwards. So hopefully that is clear for everybody. So when we met with the 3 groups of health professionals, we walked through basically what it's like to walk in their shoes as a health professional, and looking at their feelings and needs and ideas around what is it like for somebody who accesses help through the emergency department, explored their feelings, the reasons why they were feeling that way through those various touch points. So everything that's been shared in the conversations has been captured, and we're today showing you the most common themes, but all the data, of course, has informed all of that. So as I said, this is all about understanding what it's like to be in your shoes as a health professional. So Mitch and I will just share the slides. We'll just alternate a little bit as we go through here. In terms of people finding help, we've been told that people generally fight the need to go to hospital because some have had previous traumatic experiences. But that unfortunately ED is the default option for many in the absence of other 24/7 services. First responders talk to us about experiencing frustration with coordination of responders, police and ambulance having different priorities, and I guess they have different responsibilities that they have to actually adhere to. So complicated family situations can be stressful when attending someone in distress, and ambulance gives assurance that the hospital is the safest place to take someone in distress, but they said to us that they know that that may not always be the case, and they find that really quite difficult. Police are looking for a way to avoid taking people to the ED. Some of the comments that people made, because it's always those stories that bring people's experiences to life. You know, the ambulance service has to adopt a clinical response. We want to tell patients we're taking them to a safe space, but we know it's not always true. It's a very busy environment where handover to ED staff is tricky. That things other than mental health are drivers for going to ED, and it's important to remember that you know, people may find themselves in crisis due to a relationship breakdown, for example. That there is only one way route to ED at the moment because of the lack of alternatives. So we found that really there was a very strong appetite from health professionals to have an alternative for people. And talking there, of course, about it being that default option. So over to you. Can you see those slides?
I can see them.
Great. They're just, I think there's just a delay, everyone, so just bear with us if there's a bit of silence between handover.
It's either that or I've got a problem with my mute button, either way. So at the arrival and initial assessment phase, so just kind of running through some of the key themes that we heard throughout this phase in the patient journey. If some patients who present to ED can be problematic, we heard that I guess a kind of violence in the ED clearly and obviously can be a risk that needs to be managed. Many patients are assessed for other things other than suicidality. So I think this is kind of mainly in regards to alcohol and other drugs amongst other issues. Tension always exists between LHD time constraints and trying to support someone in the worst time of their life. LHD staff are often burdened by administrative and procedural documents rather than supporting someone through a crisis. Quite clearly linked to the point above there as well, that it's a very kind of busy and chaotic job to do. It can be quite difficult to manage everything that comes with a suicidal crisis at the same time as ensuring due process is adhered to, I guess. And we heard quite a bright spot around it. Peer workers have been used successfully to engage with people in suicidal crisis and avoid hospitalisation or unnecessary care. So it was great to hear. Some of the powerful quotes that fell out of that as well, starting from the top left of screen there, that many patients with history of suicide attempts can be assessed as having other issues, e.g. problematic use of alcohol and other drugs. And much of our time is taken up with administrative and procedural documentation. ED staff have very variable capability in meeting the needs of mental health patients. They get very little suicide-specific training. Even to reach triage can take more time than expected. In the meantime, the environment isn't ideal, is very loud and distracting. And lucky last, top right there, is very difficult to let someone know their story, given the busy, stressful and intense physical environment. It's all very powerful quotes from that some initial access and assessment phase things. So back to you, Bonnie.
Thanks. So then we were talking a little bit about waiting, and the fact that the ED environment's really overwhelming, and health clinicians were telling us it's overwhelming for them as well, that it's not an ideal to see, to see people and to really support them the way they want to. There was, as Mitch was saying, there has been success was pointed out in terms of peer workers being in ED, and even the fact that they can resolve an issue before hospital admission is required. So just being able to have that access to a peer worker was just incredibly helpful in the ED environment, which hopefully is something, well, it's clearly something the LHC is starting to do, which is fantastic. And hopefully, you'll see that expand in the zero suicides in care work that you'll be doing as well. But there were comments around that long waits can occur due to log jams in trying to find patients a bed for admission, and that patients are at risk of leaving due to a variety of reasons. But in that waiting period, if there hasn't been that opportunity to see them and to let them be heard fairly quickly, that people can actually leave, which of course is problematic for everybody. So in terms of experiences of the health professionals, talking about, ED is a very busy place. Patients can experience a lack of privacy and confidentiality. So that was another thing in terms of a risk of just getting up and leaving, that they're just not comfortable in that environment. Recently, someone stayed in the ED for 72 hours. The time spent waiting in ED caused the exacerbation of their condition over time and eventuated in an admission that could have been prevented with earlier support. And often a peer worker, once again, can help resolve that and get people on their way to support that is going to be helpful. And people in suicidal distress can be required to wait in a secure area, which is essentially a room with a mattress on the floor. It destroys any rapport you've built up with them. That was a really powerful comment, because it was by a person who doesn't work actually in ED, but is often involved in supporting people to go and access support. And so that rapport has been built, and then the environment of ED actually jeopardises that relationship. Over to you, Mitch.
Cool. So moving on to the treatment part of the journey. So many patients have traumatic past experiences with the ED and inpatient unit. I think it's really, really important in the consideration of designing a safe space is to get that kind of balance of safety and security right with what might be quite a traumatic time for someone in previous access of the ED or inpatient unit. A staff member had heard a positive report of a patient experience officer in the ED, so providing care and support to people in ED waiting and when they're, they're receiving treatment. So that was quite heartening to hear and something to build on. The integration and coordination of mental health clinicians and ED staff can be challenging. So I don't think that is isolated to this particular region at all. But there's just kind of layers of complexity, there in kind of designing something, new. So last point there being ED staff are generally not in the best position to provide care for patients due to I think it says the busy environment, which I assume has just been cut off there. So that's cool. So moving through to some quotes about the treatment phase. So a lot of patients state they have a bad experience with the ED or inpatient unit, so trust is always an issue. We acknowledge that many people have had traumatic experiences with previous hospital admissions. But providing care and support in the after hours period is a significant issue. Anything after 8 p.m. it goes to ED, like many LHDs across yes, New South Wales and Australia, it's always going to be a problem. ED staff are not in the best position to provide care for people experiencing distress due to the nature of the ED environment. So as I said before, a busy, loud, intense is quite challenging to deal with something quite sensitive.
So when we then looked at the situation of when somebody's been through ED and is leaving, being discharged, there was an acknowledgement that it's actually quite a challenge to actively link people with ongoing support and to be even providing information on that transition, you know, where to from here, what does it mean? That there has been some recent success of utilising peer workers to support in that transition phase. And the comment was made about there just being so many NGOs who do provide support, but there doesn't seem to be any central coordination of that. And as a result of that, it's really difficult to navigate where support could actually be accessed for people. So it needs coordination. So obviously a large piece of work, but something that would be particularly helpful in supporting every sort of service that's in this space. So in terms of comments, ideally our peer workers would be able to follow up each person after an admission and presentation at the ED they're talking about there. Peer workers are effective at supporting transition back to community. There's the potential to enhance efforts regarding safety planning, for example, utilising the Beyond Blues Beyond Now app to facilitate person-led safety planning. There's many providers delivering services, just hard to keep up with them all. And during COVID-19, we were actively working with known patients to keep them out of the ED, which we were able to do with temporary resourcing. So, you know, the health professionals were commenting that, you know, it is possible and they've been able to do it during this really unusual time with that extra resourcing. So brought us then to say, well, okay, what's actually needed? Now, once again, I just want to reiterate that, you know, we understand that there's been quite a bit of work done by various stakeholders, and we're really looking forward to receiving that information. But what does an ideal safe space look like in our region? From our conversations, this is what's been shared with us. So from an experience perspective, it's about a place that's welcoming and comfortable. The autonomy of the person is prioritised, and that staff have the time to learn the story of the person and facilitate a warm handover if required. It involves family and carers, but also respects the wishes of the person who's needing the support of the safe space at the time. From a connections perspective, links to and from the LHD and the broader community services are going to be important. Direct access to clinical care nearby is required, with an acknowledgement that not everyone will need a clinical response. The default should be to care for people in community with an aim to be able to send them home from the safe space. And that strong relationships with staff and teams at the LHD will be really important, and that staff have a very good understanding of available support for all different sorts of social determinants. I'll let you continue, Mitch.
Cool. So when talking about staffing and workforce, I'll just kind of make my way through these points here. So their confidence gained through a blended model of peer workers and clinicians, adequate staffing and coverage over shifts, which I understand will always be a challenge given the resourcing available. Staff trained in de-escalation, there's direct access to clinicians, not necessarily on site, but within reach. A speed dial line to clinical support of peer worker and guests want to access that. So just having that very quick and ready access to escalation in care if needed. And if a clinician on site in front of house are all peers and clinical in the back room. So really trying to get that non-clinical feel to enable as much access to the service as possible. So continuing over on the right here, as processes to ensure peer workers operating in a safe environment access assist supervision, which is links very, very tightly with the New South Wales Ministry of Health guidance about this. Service and managed by clinician to manage risk. So told that a number of times. Regarding environment, ideally off-site from the hospital. It reduces stigma of accessing and create more of a positive environment. The building required to be safe and secure while not re-traumatising people who may have had a negative past experience. Certainly something that's really, really important to enable access to a broad selection of the population. As I said before, a real focus on a non-clinical environment. I think we're quite highly valued by both health professionals and people with lived experience.
And then finally, across to governance and access. So there wasn't a lot of discussion around the governance in these particular health professional focus group conversations, but that there was agreement around a duty of care and clinical required prior to establishment. So just looking for that really good governance, which, you know, absolutely speaks to the ministry's statement of requirements. They very clearly state that there needs to be a very robust governance structure in place to support the peer workers to be able to access clinical care as and when it's required in this non-clinical space, and need to determine where the clinical governance actually sits. From an access perspective, people really wanting no barriers, streamlined access, no wrong door, and that people aren't just assigned a number and left to wait to be assessed, that it's a non-clinical front door, and that the people are welcomed and really attended to straight away when they arrive at the safe space. All right, so we're going to stop sharing slides in just a moment and come back to you and see if anybody has any questions. But the webinar recording and the survey links, well, the survey link is already up on the website. The webinar recording will be there by this evening. So you can go to the Roses in the Ocean website at rosesintheocean.com.au/Mid North Coast LHD, and you'll find a landing page there with all of the information. It's something that you've received if you've been participating already. Otherwise, please get a copy of that link now. And we really would love you all to be sharing this far and wide. Please, to all the other health professionals in your networks, community members, other areas of community that you're involved in outside of work, the broader the community that we get to actually participate in these surveys and in this process, the better that it will be for all of you. So I'll just stop sharing now and come back to screen, and we'll just see if there are any questions for Mitcha and I in terms of what you've heard so far. This is where it's always very quiet for a little while somebody's typing. Just while we're waiting to see if anyone has any questions for us, in terms of next steps. So earlier this afternoon, as I mentioned, there was another feedback loop webinar around the lived experience contributions so far, and you can find that webinar to watch and a survey, it's the same survey, but that webinar to watch on that landing site as well. It's good to be hearing what everyone is doing. But we will then be reviewing all of the co-design work that is shared with us by the LHD, hopefully in the next day or so. Start weaving that through into the next stages, and we will then bring that to the next stage of the co-design process, and then in the surveys keep expanding on what you have already developed, but also start looking at what questions really need to be discussed with what's being put on the table now. How does that align with the ministry's statement of requirements? Where are areas where lived experience and health professionals are really nicely aligned? Where are areas that really need some further exploration together and some creative problem solving? And so we just keep moving this process along until we come out the other end with a service model that is collectively owned and supported by everybody. So at this point, we don't have any questions coming through. So look, we will sign off then for the afternoon. Thank you all so very much for joining us. And please, as I say, please go to the landing page, rosesintheocean.com.au /Mid North Coast LHD, and and complete the survey. There's just one comment that's actually come through, which we'll do just before we sign off. Someone's saying they'd be very interested in further discussion around the non-clinical environment and suggestion of having a service manager clinician. Yeah, so thank you for that. We will capture that and be sure to put those comments in the survey as well. And that will be something that definitely comes up in further conversation, I'm sure, when we're looking at the alignment between the ministry's requirements for these projects and what your community is asking for. All right, everyone. Well, thank you so much for joining us, and we look forward to seeing you all soon. Thanks so much. Bye.
Thanks, everyone. Bye-bye.